What's up, everybody? My name is Dr. Garrett Rossi, and I'm a board-certified psychiatrist who makes mental health content here on YouTube. Now, if you're new to this community, I would love to make you a member by subscribing to the channel. It really helps me to know that this information is valuable to you. And if you're a returning viewer, thank you so much for all of the love and support. I truly do appreciate your interest. Now, last week, we covered anxiety disorders and the diagnosis, and we covered specifically a lot about generalized anxiety disorder. So we discussed specifically that disorder, the diagnosis, what are some of the problems with it, what are some of the overlaps with generalized anxiety disorder and major depressive disorder. Now we're going to take a look at the research associated with the treatment of generalized anxiety disorder. And we're going to let the research inform our decision-making about what treatments really work. So what I want to do is tell you what actually works. And you might be surprised about some of the findings that we have here and other things you might not be super surprised about. So today's video is titled The Truth About Anxiety Treatments, What Really Works, and we're going to crack into it right here. So I hate to do it to you guys, but you know I have to talk about them, and that is the serotonin reuptake inhibitors, or SSRIs. So SSRIs, although they're not very effective for the treatment of generalized anxiety disorder, the effect size is approximately 0.33, which would fall in the low range when we're thinking about effect sizes. They still remain a first-line treatment in many algorithms. So most of the time, if somebody's presenting with generalized anxiety disorder, they're going to be started on a selective serotonin reuptake inhibitor. Now, it's important to confirm that somebody has had an adequate trial. I've talked about this many times. So when someone comes to see you for the first time complaining of anxiety, you should first be sure that they've had an SSRI trial. If they're coming for medication, they might be coming for psychotherapy or other alternative natural products, which we will be talking about in this video. But let's say they're coming in for medication management because the anxiety is so bad, nothing has worked. They tried psychotherapy. Now we're at medication. Confirm that they had an adequate trial first. And what an adequate trial is, it means the person's been on the medication for a good number of weeks, say 4 weeks minimum in most cases, and that the person has also achieved a high enough dose of the medication to make sure that it works. So the two parts, again, to an effective trial is, has the person been on the medication long enough, and have they reached an effective dose? Because if you're on 25 milligrams of sertraline and you've only been on it for 2 weeks and it's not working, well, there's a couple problems there, right? Now you might be asking, which SSRI are we going to choose here? Well, the choice of SSRI will largely depend on the side effect profile and other patient factors. Those patient factors can be things such as the presence of insomnia, substance use disorder, and of course, things like pregnancy might influence your decision. Now, a good first-line option, and this is old hat, is going to be something like escitalopram or fluoxetine, and sertraline can be other good first-line options. So if you're trying to treat a generalized anxiety disorder, the person's never tried these medications before, one of those three could be a good option. Now, although paroxetine, I've talked about this before, paroxetine is never the right answer in psychiatry, at least not for me. And I would challenge you to show me differently here and show me different evidence proving that it's significantly better than the other examples I've given you. So although paroxetine has FDA approval for generalized anxiety disorder, it has a slew of side effects that are unpleasant, things like sedation, the most weight gain of all the SSRIs, and of course it's teratogenic in pregnancy, so you wouldn't want to give this to somebody who is pregnant. So there's a lot of problems with it. It's a poor first choice, even though it is FDA approved. Now, if the first medication trial doesn't work or is ineffective, what do you do next? The next thing you're going to do is try possibly another SSRI medication. So you could switch to a different SSRI, or you can make the next jump here, which is going to be to use one of the serotonin norepinephrine reuptake inhibitors, and we're going to talk about that in the next section. So what do you do when the SSRIs do not work? Okay, so you've either had a trial of SSRI or had 2 trials, say you switched to another SSRI and nothing's working still. The next step would be in many cases to switch the medication class, right? So the next option would be to change from a serotonin-based medication to a serotonin norepinephrine-based medication. Now there are 2 SNRIs that have been studied in GAD, venlafaxine and duloxetine. So venlafaxine, duloxetine, 2 options. Now, venlafaxine I don't have as a first-line option in my algorithm. And one of the reasons behind that is the side effect profile, in my opinion, is much more harsh, and there is only a small increase in efficacy when you switch from an SSRI to an SNRI. So what we're saying here is venlafaxine is not a great option because of its side effect profile, because of its high risk for withdrawal if somebody were to miss a dose of medication, and because there's only a small benefit over SSRI medications. So what that tells us here is a couple of things. One, the effect size of SNRIs compared to SSRIs is 0.33 in SSRIs versus 0.36 in SNRIs. So again, a very small benefit that you probably wouldn't see clinically even. Wouldn't even be clinically observable. But again, we don't know who's going to respond to what medication better. Sometimes somebody switches to a medication like venlafaxine or duloxetine, and they do amazing. And it's something that's really changed and revolutionized their entire life. In other cases, again, we don't see that much of a change, but when it comes to effect size, they're quite similar and probably wouldn't be detectable clinically. Now, duloxetine can be a good option here, and it's a slightly better option with respect to the side effect profile. One thing that's important to know about duloxetine is it has a lower risk of sexual side effects, so if sexual side effects are a major concern, then this might be a better option for somebody. And it also has been approved for anxiety disorders. So this could be a good choice if you're choosing an SNRI medication to treat generalized anxiety disorder. You might want to start with duloxetine. And there are other added benefits as well. Things like it's been proven to be somewhat helpful in pain syndromes. It's also been proven to be somewhat of a cognitive enhancement associated with depression. So depression often causes people's cognition to be slightly lower and not as good as it normally would be if they weren't feeling depressed. So there is some cognitive benefits as well to possibly using duloxetine. So duloxetine remains a good change if you're going to go with a different class of medication, specifically the SNRIs to treat generalized anxiety disorder. If you trained in psychiatry like me and you've worked with a lot of different people, you'll often hear people say that bupropion or Wellbutrin is a poor choice for generalized anxiety disorder. This is not entirely true. So this is one of the myths we're going to dispel here, is that you should never use bupropion in generalized anxiety disorder. There actually is evidence to support its use. There was a small 25 participant trial where bupropion actually beat the SSRI escitalopram head-to-head. So we have a head-to-head comparison in GAD of bupropion, escitalopram, and bupropion came out ahead. Now granted, that's a small number of participants. You got to take it for what it's worth, but still, that's evidence to support its use. There are other lines of evidence that include more improvement in generalized anxiety disorder symptoms when bupropion is added in combination with SSRI than buspirone. So buspirone is actually FDA approved, right, for generalized anxiety disorder, but there seems to be more benefit, at least from this study, when bupropion is added to an SSRI versus adding buspirone. So this is another piece of evidence that will help us to understand. Now for clarification, the effect size of buspirone, so not bupropion, buspirone in GAD is very low and very poor. It's actually negligible in my opinion clinically. So the effect size for buspirone in GAD is 0.17. So you can again compare that to the SSRIs and SNRIs at 0.33 and 0.36. In GAD, it's actually 0.17, which again would likely not be able to show any clinical improvement in anxiety symptoms. So that's one of the reasons why I stay away from buspirone. I only really use it to treat sexual side effects associated with SSRIs. And here we're seeing that bupropion might be a better option to add to somebody's regimen if they're still struggling with anxiety, despite being on an adequate dose of SSRIs. Bupropion can also be a good option for somebody who wants a lower side effect profile. Again, similar to Cymbalta, it has a much lower risk of sexual side effects. It also has the possible ability to enhance cognition and concentration. Sometimes bupropion has even been thought to treat ADHD symptoms, so you can have that added benefit as well if you go this route. Now, although we lack large randomized controlled trial studies in GAD with bupropion, we still have some evidence to support its use, and we're likely not going to get those large randomized controlled trials because the medication is generic and there's no additional interest in gaining another indication for it at this time. Another thing I just want to say is that the negative studies, the ones that kind of told us that we should stop using bupropion in the treatment of anxiety disorders, actually were not studying generalized anxiety disorder. They were studies that were talking about panic disorder specifically. So if somebody has panic disorder, you might want to stay away from bupropion or Wellbutrin. If somebody has generalized anxiety disorder, it might be worth giving a shot as an augmentation strategy or as a monotherapy, depending on the patient, other patient factors like we talked about in this section. So what about new antidepressants? This is one that I get asked about all the time by you guys in the comment section, and they'll talk about things like vilazodone, vortioxetine, etc. And when vortioxetine came out, there was a lot of hype behind it. It was really believed that this was going to work in GAD, and the same thing with vilazodone. People assumed it would work really, really well in GAD, because when you look at the mechanisms of action of these two medications, it makes perfect sense that it would treat generalized anxiety disorder. Unfortunately, that might be the story of psychiatry and psychopharmacology in general when it comes to medications. Things that theoretically on paper and mechanisms of action that should make sense don't actually treat what they theoretically should treat. So unfortunately, that's where we are with these. And what I can say about it is the effect size for vortioxetine was so small that it was even smaller than buspirone. So the effect size with vortioxetine for GAD was only 0.12. So people often argue with me and say, oh no, it works for GAD, you know, blah, blah, blah. Well, I mean, yes, maybe again, an individual case-by-case basis, somebody's anxiety improves on it. But overall, when you pull all this data together in a meta-analysis and you calculate an effect size, you find that the effect size is very, very small, and again, not clinically meaningful. So it didn't even cross into the small range. So this medication performed worse than Buspar and in GAD, and I'd say that that says a lot about what's going on here. Vilazodone, like I said, same thing. There was one positive study that was published for GAD, and again, based on the mechanism of action, it makes a lot of sense. It should work just fine. It has SSRI-like effects, in addition to the 5-HT1A effects, just like buspirone has. So it's almost like an SSRI combined with buspirone in one pill. Now, I mean, it makes sense, it should work. However, this did not work, and the one positive study was followed up by two negative studies with a calculated effect size of 0.26, so slightly better than buspirone alone, slightly better than vortioxetine, but not much better, and is still considered small. And both of these medications were not submitted to the FDA for approval for GAD based on these negative results. So the drug companies, who are often, you know, looking to get more indications to make more money, right, chose to withdraw these medications from consideration for GAD diagnosis. So it's interesting to note that they pulled these off. All right, so the hydroxyzine controversy. People comment a lot on my hydroxyzine video, and they were like, there was like kind of mixed results. Most people saying that they really didn't care for it, didn't seem to work. So let's just kind of go through it a little bit and see what this effect size overall is. So hydroxyzine is an antihistamine with low anticholinergic effects. So that's important to note because anticholinergic effects can affect things like cognition, which you're not going to want to do, and also cause anticholinergic side effects. So hydroxyzine is an antihistamine. It's been out for a long time. I stated in my previous video that it was actually FDA approved for tension associated with psychoneurosis. So the old term for what is now pretty much generalized anxiety disorder, a psychoanalytic way of describing anxiety. Now, it's often seen as ineffective. Like I said, people commented all over my video about how terrible it was and the side effects and all this other stuff. And it's often seen as you know, a less than measure that doesn't really treat anxiety. But the effect size, when it's calculated out from a meta-analysis, actually was better. It beat SSRIs, it beat SNRIs, and it worked pretty damn well for the treatment of generalized anxiety disorder. So this was quite surprising. Hydroxyzine had an effect size of 0.45, which is more in the medium range. So that's pretty good. To put that in perspective, it was actually quite similar to the effect size that we see with benzodiazepines and psychotherapy, which were right around 0.4, 0.5. So we may want to reconsider this medication as being a decent option for the treatment of generalized anxiety disorder. There are some limitations in this effect size, though, that I want to point out. With hydroxyzine, largely the studies are small and of short duration, so the medication wasn't used for long periods of time. and the number of participants in the studies was smaller than those in other medications. But it still provides a fair amount of evidence that hydroxyzine may perform better than we think, and we might want to reconsider it in our treatment algorithm. All right, guys, now we got to get into the juicy stuff here, because this one was really interesting. It surprised me. It's probably going to surprise you. We often don't think of antipsychotic medications as options for the treatment of generalized anxiety disorder. However, one antipsychotic medication performed really, really well in the treatment of anxiety disorders, specifically GAD. And that medication was Quetiapine or Seroquel. So Quetiapine or Seroquel actually works really well for anxiety disorders. Now the effect size was large, like really large, like larger than amphetamines in ADHD, larger than ketamine in treatment-resistant depression. The effect size was 1 to 2.2, depending on which study you calculate it from. But either way, that's a large effect size. And to put this in perspective, it outperformed SSRIs, it outperformed SNRIs, and it outperformed benzodiazepines in the treatment of generalized anxiety disorder. Now you might be saying, Dr. Rossi, why didn't it get FDA approval? It has FDA approval for depression, right? It does, as an adjunctive treatment. You can use Quetiapine or Seroquel for cases that don't respond appropriately to first-line options. So if you watch my other videos, then you should know that the side effect profile of Quetiapine is quite harsh and it's difficult for people to tolerate. Metabolic side effects and sedation being the most common problems that people experience, but they're serious ones. And the FDA itself does not seem to view anxiety disorders as significant of a disorder that warrants this degree of risk. So the FDA doesn't believe that anxiety disorders are in the same, I guess, category as depressive disorders. So one place where you might really be able to get a lot of value from this medication, though, is in the cases of bipolar depression where the person has a lot of anxiety as well. So if somebody has a lot of anxiety and they have bipolar disorder and you're not going to use an antidepressant anyway, you might want to consider Quetiapine as a good option here, and from the evidence and the research we have, it would be a damn good choice. So we want to avoid antidepressants in that population at all costs. Quetiapine can be the option there for bipolar depression with a lot of anxiety in place. So where does Quetiapine fit clinically into the algorithm here? Well, for me, it fits as like maybe a third or fourth line option. I don't think this is a first or second or maybe not even a third line option, honestly, because again, the side effect profile is quite harsh. You want to explore all other potential avenues. The one place where we may consider this as a first line option is somebody with bipolar depression. This could be a really good option when that person also struggles with a great deal of anxiety. And I want to point out that other second generation antipsychotic or dopamine blocking medications have also been successful and known to have a positive effect on anxiety disorders. Again, the limitation remains their side effect profile, which the FDA is reluctant, obviously, to approve, and patients are also reluctant to take because it is a lot to consider for an anxiety disorder. So I just want to take a real quick detour here away from the medications and just talk about how the view of anxiety by society in general is a less severe form of psychiatric illness. We're not really viewing anxiety the same way we would other disorders, right? According to the FDA, medications like aripiprazole or Quetiapine are perfectly reasonable adjunctive treatments for somebody with major depression that doesn't respond to first-line options, but it's not appropriate for anxiety disorders as evidenced by Quetiapine not gaining its FDA approval. So this is not their view, like I said, for anxiety disorders. They don't see these as first-line options. But when we look at disability caused by depression and anxiety, there isn't really much difference. So the odds of being disabled for depression versus anxiety is 3.5 versus 3.1. So somebody who's going to be disabled as a result of one of these mental health conditions, either depression or anxiety really is about the same. So the odds of being disabled for one or the other really is equal almost. So for whatever reason, we continue to view anxiety as a less severe form, although the DSM doesn't really guide us here, because it doesn't provide us a diagnostic hierarchy to say what should be treated as more significant. Now, to kind of cap this part of the discussion off, things like psychotherapy are often recommended as first-line options. I always recommend psychotherapy to all my patients. I think it's a good thing regardless of your diagnosis and regardless of what type of treatment you're looking for. And in the 1980s, when GAD was first conceived, it was thought to be a mild disorder. So the way they were thinking about it when they were getting ready to put it into the DSM and change this psychoneuroses thing to GAD, it was thought to be a mild disorder that was best treated with psychotherapy. So psychotherapy remains a first-line option, and it does perform pretty well. In fact, psychotherapy did have an effect size of 0.5, which is quite similar, again, to benzodiazepines, about the same, actually, as benzodiazepines. So psychotherapy can be very effective for the treatment of GAD. And it's always a good place to start. I'm also a big believer, like I said, in the combination of psychotherapy and medication for anxiety disorders. So I don't want to talk too much about benzodiazepines, but I'll make a quick comment on them here. One thing to note about benzodiazepines is that they have all sorts of effects on the body. It's not just related to anxiety. And largely, we think of the benefits of benzodiazepines and anxiety disorders as having a major effect on the physical symptoms associated with anxiety, the muscle tension, the fatigue, that just kind of wound up feeling that somebody has, the racing heart, etc. So with anxiety disorders, benzodiazepines really shine in taking away those physical symptoms, although again, it doesn't change the fact that the person's still going to have anxious thoughts. Many of the effects of benzodiazepines also cannot be necessarily measured with traditional anxiety rating scales, so we may not be seeing the full effect of what benzodiazepines can do. Nevertheless, benzodiazepines did have a pretty large effect size, or a medium effect size rather, of 0.4 to 0.5, which falls into the moderate range or medium range for GAD. So my final option for generalized anxiety disorder is one that I've actually enjoyed learning about because I'm a big believer in utilizing all the things that work, including natural products. And of course, this is going to be Silexan, which is the proprietary extract of lavender oil that has actually a very large effect size in the treatment of GAD. In Germany, there's a lot of respect for the power of natural products. In the United States, not so much. Usually they're like snake oil that's sold over the counter, and guys taking steroids say, you can get jacked or whatever in the gym if you just take this supplement, for example. That's obviously not true, and people are skeptical, right? Which is fine, and I'm skeptical too. I think we should all be skeptical, at least initially, until we see the evidence. So in other countries, these lavender extracts and other natural products are regulated, taught in medical schools, and prescribed in the same manner as pharmaceutical drugs. So when Silexan was studied for GAD, the effect size was actually found to be 0.5 to 0.9. So this is significant. This is a pretty moderate to large effect size for the treatment of generalized anxiety disorder. And I have a video that covers all the details on Silexan if you're interested. You can see it in my content library. This can be added to most medication regimens, so without significant drug interactions. So if somebody is on benzodiazepines already and wants to try to come off of them and worried about their anxiety getting worse, you could start Silexan while you're doing a benzodiazepine taper, for example, and it has actually been shown to help people reduce the use of benzodiazepines. So this could be a really good option here. Another thing that's nice about this is this can be purchased over the counter. It's sold under the brand name Calm Aid. It can be had for about $30 a month. If you're wondering, I don't get any financial compensation for saying that. I have no affiliations with the company. I only want to do what works and present to you guys that information and those details. So it does work. There are studies that prove this, and it is a reasonable option. And there's really not much downside to potentially trying it if you're still suffering from anxiety despite other treatment modalities. Okay, so we've come to the conclusion of this video. We've covered a lot of details here today. Let's finish it off by saying that I think one of the most important things I want to stress here is that you're finding the underlying cause of your anxiety. Because like I said, even if you take benzodiazepines or any other medications that alleviate some of these physical symptoms of anxiety, nothing is going to get rid of those anxious thoughts unless you find a way to change the way you're thinking about things. So I believe anxiety is largely driven by other underlying factors, like we discussed in the previous video, where you could probably find many causes of anxiety, including personality traits that may be driving this anxiety, and getting to the bottom of that is going to be essential for you to understand and come up with a treatment plan that works for you. There are many reasons to be anxious and all require a different approach. Without that clarification, it's hard and most people are going to continue to struggle. Another important point here is that theoretical mechanisms of action that should treat things don't always work out that way. So we looked at that in the case of medications like vortioxetine, where we saw that, even though theoretically the mechanism makes a lot of sense for the treatment of generalized anxiety disorder, the clinical research did not pan out and the companies withdrew their bid to try to obtain approval for generalized anxiety disorder. We also had some surprises here. Like I said, we should probably reconsider the use of hydroxyzine. That seems to work fairly well. We should also consider natural products like Silexan. There are a couple others I didn't mention here, but Silexan is probably the most well-researched one at this point, in addition to traditional first-line options, and that we should have an algorithm-style approach to what medications we're choosing and how we're making those decisions. So I hope this discussion was helpful for you. If you want more content related to anxiety disorders, let me know in the comments section below. And if you haven't done so already, please consider subscribing to the channel and liking the video. It absolutely helps me to keep making this thing happen. So thanks again. I'll see you in the next one.